Inclusion and exclusion criteria. We chose to adopt the NLST and the CMS inclusion-exclusion criteria for our program, and they were very much the same. Our early program only included those current or former heavy smokers who were aged 55 to 74. However, after the national coverage decision by CMS, they have increased the upward age up to 77. Patients must be asymptomatic for lung cancer, have a 30-year history of smoking, quit smoking less than 15 years ago, not had a chest CT in the past 2 years, and have no history of malignancy. Some have asked, why not just include everyone in your program? First of all, including everyone in your program will surely mess up the quality and outcome registries that are mandated in order to run a lung cancer screening program. CMS has decided that screening for lung cancer is only valuable in those specific populations, and inappropriate screening is not cost-effective and potentially harmful. History of malignancy. This was a little bit tricky for us at our institution. Again, the NLST guidelines for enrollment stated that those participants who had a history of non-life-threatening malignancy were not declined enrollment and were allowed to participate in their trial. The question we struggled with is, what is the definition of a non-life-threatening malignancy? How would we educate our staff technologists, scheduling staff, and finance staff, and the like to know that difference? So we opted to exclude any patient with any history of malignancy from our program. As you can imagine, this led to pushback from referrers and from our patients. Our rationale was that a patient with a history of malignancy is already under some surveillance using established protocols. Patients and referrers would use this low-cost system to perform surveillance imaging to avoid the high-cost insurance deductibles. But we have lately come up with a new thinking that perhaps we should make enrollment decisions in these patients on a case-by-case basis. We are seeing patients with remote breast cancers or remote prostate cancers that aren't undergoing any surveillance and allowing them into our program. We do realize, though, that this takes extra time and effort to investigate these patients and figure out whether or not they can be included in our program, which can lead to scheduling issues and delays.